So there are a number of areas where risk factors for psoriatic arthritis among psoriasis patients can be identified, and we can look at epidemiology of psoriatic arthritis in patients with psoriasis. We can look at clinical factors, environmental factors, genetic factors, and biomarkers. Epidemiologically, we know that about 70% of patients with psoriatic arthritis present with pre-existing psoriasis, and it can be as long as 30 years. About 15% of the patients develop their arthritis and psoriasis at the same time, or certainly within the year. And then another approximately 15% actually present with arthritis before the psoriasis. Now, you could argue that some of these patients probably have psoriasis and it was missed by the physicians because there are these hidden areas that some people don't look at or look for. And in a study that was done in the Netherlands in about 2003 suggested that in fact even rheumatologists are not good enough in terms of identifying patients with psoriatic arthritis. They took 2 patients and sent them to 15 consultants to determine the diagnosis. And the patients had a sheet that they could mark whether or not the physician asked them about psoriasis, family history of psoriasis, examined them for psoriasis, etc. And it turned out that only 15 of 23 consultants actually came up with the right diagnosis. And the main reason for not identifying psoriatic arthritis was not asking about psoriasis, not asking about family history of psoriasis, and primarily not examining the patient. So whether or not all of these people actually do not have psoriasis or have missed psoriasis is not clear. But there is a group of patients who do not have psoriasis at the time they present with psoriatic arthritis, and so some of the risk factors for developing psoriatic arthritis in this particular patient group may be different. So now what about the incidence of psoriatic arthritis? Lihi Eder did that as part of her PhD thesis, and what we did is we started a cohort of patients with psoriasis without arthritis at our psoriatic disease program. And so patients coming to this particular clinic, they're invited if they admit to having psoriasis and no arthritis. To start with, 12% of those who referred themselves to this clinic actually had psoriatic arthritis. So of course they are now followed in the psoriatic arthritis clinic. But of a group of 313 that we confirmed psoriasis without arthritis at inception, 10 developed psoriatic arthritis within the first 4 years of follow-up for an annual incidence of 1.87 per 100 patient years. So it's almost 2% per year. If you look at, this is assuming that the patients not coming back for follow-up did not have psoriatic arthritis. But if you look only at the observed patients, the incidence rate actually increased to 2.53. So now if you look at the series of patients that have been described from various clinics around the world, when they look at their patients with psoriasis, they identify about 30% having psoriatic arthritis, and when you look at the disease duration, on average, they've had psoriasis for about 15 years. So it certainly is consistent with this incidence rate. Now, the other thing that's interesting is that the risk for developing psoriatic arthritis among psoriasis patients is constant over time. So we saw that in our own series. This is a series from Germany where you can see that there is a linear relationship between the duration of psoriasis and the development of psoriatic arthritis. So epidemiologically, this is a significant risk. Now, what about clinical factors? There are a number of clinical factors that have been identified in terms of those patients with psoriasis that are most likely to develop psoriatic arthritis. Nail lesions have been identified as a major risk factor. The extent of psoriasis and the site of psoriasis have also been identified. So this is one of the first studies that came out of the University of Toronto psoriatic arthritis program. It goes back to 1986, so I guess some of you weren't there or in this world at the time. But what you can see is this is looking at a group of 158 patients with psoriatic arthritis and 101 patients with psoriasis who, again, were reviewed by a rheumatologist to make sure that they did not have psoriatic arthritis. They all underwent both clinical examination, laboratory investigation, and radiographs. And of patients with psoriatic arthritis, 84% had nail lesions compared to 46% of patients with psoriasis without arthritis. And that was the only clinical feature that distinguished between those two groups. More recently, in Shireen Gabriel's group at the Mayo Clinic, they identified scalp lesions, intergluteal perianal lesions, as well as nail dystrophy as being associated with psoriatic arthritis. And in a study that was done in Dublin, similar to the study that Philip Hellewell described yesterday, where they looked at 100 patients with in the psoriasis clinic and 100 patients with psoriatic arthritis in the rheumatology clinics. When they looked at single item analysis, they found that the PASI score, the extent of psoriasis, nail lesions, and scalp lesions were in fact associated with psoriatic arthritis. But when they did a multivariate analysis, only the PASI score remained in the model. Now, we've seen this study from Paolo Gisonti yesterday. This is a study of ultrasound evaluation of the entheses. And the important thing here is that not only did they identify more thickness in patients with psoriasis, but at follow-up, 10% of the psoriasis patients progressed to develop psoriatic arthritis over 2 years. So that's even a higher incidence than we described based on our population study. So there are epidemiological and clinical features that help distinguish. What about environmental factors? So the group in Manchester, Ian Bruce actually trained with me in Toronto and has gone back to do both lupus and psoriatic arthritis in Manchester. And so they looked at the group of patients that included 98 patients with psoriatic arthritis and 163 patients with psoriasis. And what they found was that rubella vaccination, injuries sufficient to require medical attention, recurrent oral ulcers, and moving house were associated with psoriatic arthritis. Lihi Eder did a similar study at the University of Toronto, but here we have a higher number of patients, and we actually did a case control study with 159 patients with psoriasis without arthritis and 159 patients with psoriatic arthritis. Importantly, all our psoriasis patients, again, having been reviewed by a rheumatologist to confirm the absence of psoriatic arthritis. And patients were matched on the duration of psoriasis, again, to make sure that patients with psoriasis had the same opportunity to develop psoriatic arthritis as those with psoriatic arthritis. And the recall was just within the last 7 years. And what you can see is that the smoking status, never versus ever, was actually protective. And there are a number of reasons for that we're actually still investigating. Occupational tasks, such as lifting heavy weight, was certainly associated with psoriatic arthritis, similar to what the Manchester group found. And then infections that required antibiotic treatment, so more bacterial infection than viral infections, were associated with psoriatic arthritis. So there are also environmental factors that are relevant here. What about genetics? So we talked about genetics of psoriasis and psoriatic arthritis yesterday, and we talked about the MHC being a major susceptibility factor. This again shows you the family history, and it's basically what I showed you yesterday, but just again to remind you that the risk recurrence for psoriatic arthritis is actually higher than the risk recurrence for psoriasis. And in fact, we did a similar study that has yet to be published, where we looked at consecutive probands with psoriasis, not with psoriatic arthritis, and looked for psoriatic arthritis and psoriasis in their relatives, and we came up with very similar risk recurrence rates that we've seen in the psoriatic arthritis probands. Now, again, Lihi Eder did this as part of her PhD thesis, and what she found was she actually looked to compare patients with psoriatic arthritis to those with psoriasis without arthritis, again confirming absence of psoriatic arthritis among the psoriasis patients. And what she found was that the HLA-B8, B27, and B38 were associated with psoriatic arthritis. And you can see that in the univariate analysis and in the multivariate analysis, those remain significantly associated both in terms of odds ratios and in terms of the p-values. On the other hand, HLA-C6 is lower in psoriatic arthritis compared to patients with psoriasis without arthritis. I showed you yesterday that HLA-C6 is increased among patients with psoriatic arthritis compared to the general population. But compared to the psoriasis patients, it's actually lower. A similar study was done by the combination of Bob Winchester in New York and Oliver Fitzgerald from Dublin on the Dublin population. And again, you can see that there is a reduction of C6 comparing psoriatic arthritis to psoriasis without arthritis. There's an increase in B57, B27, C1, C2, which are in linkage disequilibrium with B27, and B38, and C7. So very similar, in fact, almost identical findings in those two studies. It's always nice to have a paper come out immediately after your paper that confirms your findings. Now, the other interesting thing is that the HLA-C6 is associated with a later age of onset in psoriatic arthritis. So there is a lower frequency of HLA-C6 in psoriatic arthritis compared to psoriasis, and those patients with psoriasis who develop psoriatic arthritis, who have the HLA-C6, develop it later on. And you can see here the early age of onset. You can see the differences in HLA-C6, but in a later onset, there is no difference. They have the same frequency. And similar observations were reported by Bob Winchester from the study I just reported to you. What they did here is they look at the time interval between the development of psoriasis and psoriatic arthritis, and you can see that B27 occurred closer to the development of psoriasis, whereas C6 was much later, 10-year difference. So again, the HLA-C6 has a protective effect for developing psoriatic arthritis in patients with psoriasis. One of the other things that we've identified that I did not put into this talk is the fact that there is an interaction between smoking and C6, and there is also some information on nicotinic acid receptors, which is the area that we're currently investigating. Now, another gene that's associated with psoriatic arthritis is the MIC-A, and the MIC-A 00801 is the one that's associated with psoriatic arthritis compared to psoriasis. So it differentiates patients with psoriatic arthritis from those with psoriasis. Now, all of these studies were done comparing patients with psoriatic arthritis who already have psoriatic arthritis to patients with psoriasis who do not yet have psoriatic arthritis. One of the things we're looking at the moment is because we've got this prospective cohort, we now have, out of about 580 patients, we have 45 who have developed psoriatic arthritis, and we're now testing whether these particular genetic differences that we've identified from the cross-sectional studies are going to be relevant in the prospective study. What about biomarkers? So again, this is a study that I showed you yesterday from Vinod Chandran, but this table shows the comparison between 26 patients with psoriasis without arthritis, again, all seen by a rheumatologist, and 26 patients with psoriatic arthritis who are matched on age, sex, and psoriasis duration. And what you can see, I would draw your attention to the reduced model, high sensitivity CRP, higher in patients with psoriatic arthritis than patients with psoriasis without arthritis. The OPG, osteoprotegerine, is higher in patients with psoriatic arthritis compared to psoriasis. Matrix metalloproteinase 3, again associated with psoriatic arthritis. And the ratio between two cartilage biomarkers, CP2 and C2C, is also associated with psoriatic arthritis. What I haven't put in here is, again, the study by Christopher Richlin, which has shown that patients with psoriatic arthritis have much higher prevalence and numbers of osteoclast precursors compared to patients with psoriasis without arthritis. And Christopher and I actually collaborating on a study that's funded by the Arthritis Society in Canada, where we're looking at our patients prospectively to identify, so we measure their osteoclast precursors when they come in, and then we measure them again if they develop psoriatic arthritis to determine whether we can actually identify that right at the beginning or whether a change occurs at the time of development of psoriatic arthritis. So this study is ongoing. So what I've shown you is that there are epidemiological features that are relevant to the risk of developing psoriatic arthritis among psoriasis patients. There are clinical factors that are important. And since everybody else has been asking you questions, I would like to ask the dermatologists in the audience, how often do you actually pay attention to the presence of nail lesions, extensive psoriasis, site of psoriasis, in terms of considering referral to a rheumatologist? Anybody? Very few. So that's something that's probably worth considering, that at least ask the right questions of those patients that have extensive psoriasis, nail lesions. Now, there's my dermatological colleagues in Toronto tell me that almost everybody has scalp lesions, and many patients have anal cleft lesions, so they don't necessarily pay attention to that. But certainly the extent of psoriasis and the nails, it's worthwhile specifically asking, as a dermatologist, if a patient has any joint pain. And then we talked about certain environmental factors, genetic factors, and biomarkers that are relevant. And while these have not yet entered the routine laboratory methods that we use, we're hoping that over the next several years, as Philip Meese actually mentioned yesterday, we're hoping that there will be some algorithm that we'll be able to develop from the combination of the clinical, genetic, and biomarkers, both serum and cellular and tissue biomarkers that might be able to identify for us patients that are likely to develop psoriatic arthritis. And of course, if we have been able to demonstrate that the incidence of psoriatic arthritis is actually lower in those patients that have been treated with appropriate therapy, then it would be a very worthwhile exercise to perform. Thank you very much for your attention.
We'll take some questions. We'll start from there.
Well, actually, you have started to answer my questions. You mentioned that among the clinical risk factor, scalp psoriasis is a risk factor. But in 80% of the patients, they have involvement of the scalp. And in fact, in 50% of the patients, psoriasis starts on the scalp. So I think it's really very difficult to connect scalp psoriasis with psoriatic arthritis.
And that could be the reason why in the Irish study, it didn't come up, whereas in the Mayo Clinic study, it did come up. And the Mayo Clinic study was more epidemiological. It's not like they went and examined patients carefully. So they only were basing their information on whatever was written in the notes. Whereas in the Irish study, they actually examined the patients and had they examined those 100 patients consecutively and had more accurate information. So that may be the case. But as I said, my dermatology colleagues in Toronto have said exactly what you said.
Mickey.
Dafna, you've mentioned among the environmental factors, the heavy lifting. We're familiar with the Kebner phenomena, which is related to trauma to the skin. How does lifting have to do with a risk factor, becoming a risk factor for psoriatic arthritis?
So it's a very good question. I do not have a definitive answer because we haven't pursued it any further, but we're all familiar with the concept of deep Kebner phenomenon as the mechanism of developing with psoriatic arthritis. So it could very well be that it's, sorry? Yeah, so I mean, the assumption would be that if you're doing heavy lifting, you are traumatizing yourself and therefore have some kind of a Kebner phenomenon. Philip Halliwell probably has some more ideas about this from the days of Werner Wright.
Yeah, Werner was a little bit skeptical about it actually, and when we did the chapter for the Klippel textbook all those years ago, we reviewed all the literature, but we extended it to other rheumatic diseases, and there's quite a good, clearly in osteoarthritis, there's a good history of trauma as an initiator, and there's a good literature with rheumatoid as well. So this association with trauma, lifting, moving house, however clear it is from the epidemiology, is not clear in terms of direct causation.
That's it.
Any more questions? Yes, please.
I have one more question. Do you think it's possible to make an absolute risk model now with the information we have? So perhaps when a patient comes to you and says, I have psoriasis, what are the chances that I will develop arthritis? You can give a more accurate number than just saying the general risk and saying, for you, it's a higher risk and you should go to a rheumatologist.
Well, like I said, I mean, we have a more accurate risk description now than we did, say, 10 years ago, but most of this information is based on small number of patients, especially when we look at the genetics and the biomarkers. So I think we still are looking for some more information before we develop the absolute model. And as was mentioned yesterday, GRAPPA is about to embark on a biomarker study that looks specifically at damage, but many of the members that are participating in this study are also looking at differences between psoriasis and psoriatic arthritis. So I think that in the next several years, we are going to be able to come up with an absolute model.
I know there are no published data, but I want to ask you about your personal belief. You mentioned PASI is one of the factors that can tell us about development of arthritis. We all know PASI is the question of treatment. So do you believe in psoriasis like in atopy? When we have atopic march, we have also psoriatic march. So if you treat the psoriasis early and you treat it aggressively, you may prevent the arthritis?
So I try to kind of remove belief from my medicine. I keep it in my religion. But the bottom line is this. The PASI score that we used, that Lihi Eder used in her methodology, was the highest PASI that was recorded for that patient. So it's not one PASI score, but it's the highest PASI score. And it basically, it's not so much for the recording of the PASI per se, but to give some idea about the extent of the disease. Now, in our studies, we matched on the highest PASI, so that we kind of removed that from the comparison. And in the other studies, like the study that was done in Ireland, they actually looked at the PASI score at the time that they did the study. So you may be right. I mean, it may be that it's not an absolute, but the fact that it comes up in more than one study suggests that at least the extent of psoriasis is relevant. And we know, for example, in cardiovascular studies, when we did a cardiovascular study in psoriatic arthritis, the one clinical feature that was predictive of developing, or was a risk factor for developing cardiovascular disease, was a PASI of 20 or more. So certainly the extent of psoriasis is very relevant to what happens to our patients. So I think that if we see patients, and in the studies that April presented to us, there is a confounding by indication, right? Because the patients that have more severe psoriasis are going to be the ones to get systemic therapy and anti-TNF agent therapy. So there's no doubt that the severity of the skin disease is very important here, both in terms of extracutaneous manifestations such as psoriatic arthritis and the metabolic syndrome and its complications. So I think that it is a marker for more severe disease, if you will, but certainly if I were a dermatologist, I would want to make sure that I do not miss development of psoriatic arthritis in those patients that have severe psoriasis. And one of the problems that those patients have is they have such severe psoriasis, so they're so focused on the skin, they may have joint pain and they don't even appreciate it. And I know that that's a fact because one of my colleagues, Chuck Lind, who does a lot of clinical trials in Toronto, has come to me on several occasions and said, I always ask my patients if they have any joint pain, and they say no. And then I give them an anti-TNF agent, and they come back 3 months later, and they say, I no longer have any joint pain. And when I say to them, but you told me you didn't have any joint pain, I have it written down in my notes that you didn't have joint pain the last time, they say, yeah, but I didn't appreciate it, but now I don't have it. So obviously, patients actually miss it unless they're triggered to actually complain about it.